My name is Eeva Pyörälä. I'm facilitator of this symposium on activity theory and medical education, foundations, findings, and future perspectives. We have here, first of all, it was a dream come true to hear Yrjö Engeström's keynote in the morning. And now we're going to continue. That was the idea when we heard that Yrjö Engeström is really coming to AMEE, which has been a dream for us for several years, that we're going to continue on activity theory, and especially on how you can apply activity theory in medical education settings. The outline of the symposium is like that. We have 3 presentations, and then we have discussions. We have first Loes Meijer's presentation. Loes is from Utrecht, Netherlands. She's worked for 30 years as a GP, and during the last 10 years she's been actively developing and also trained GPs and medical specialists to work collaboratively for the best of the patient. Then we have Tim Dornan, an eminent scholar in the field of medical education, who has devoted the last decades for studying complex workplace settings, and also seeking for theoretical and methodological frameworks for studying such settings. And he just recently published with his colleagues an important AMEE guide on experience-based learning. Then we have Professor Emeritus Alan Bleakley, who is really the pivotal person in medical humanism. And he writes so beautifully, even his titles think, well, is this a scientific article or is this a novel? Fantastic. In between these speaks, we always have time for questions and comments and discussion. And Yrjö Engeström is with us as well, so he will discuss with us, and we look forward to having your questions and comments. What we basically wish you to bring with you when the symposium is over is to really think about your own environment, your unit. And if you're really interested in studying very complex settings of medical education and interprofessional situation involving patients, intraprofessional collaboration and communication, activity theory and expansive learning might be really the real thing. And I will guarantee active discussion, because I'm a kind of the captain on the board, so I keep up with the timetable, and we will, I assure you, we will move onwards, and you will have time for discussion as well. Third thing I had to remember to tell you that the symposium material is uploaded in the guide, in the online guide. So when you scroll the symposium, at the bottom there's a PDF which contains a quite recent version of these presentations. And there are also paper versions which have been of the handouts which have been delivered there on both sides. Okay, I think we move onwards, and I give the floor to Loes Meijer.
Thank you, Eve, for the introduction. I would like to take this opportunity to express my gratitude to Yrjö Engeström for inviting me. I would also like to thank Yrjö, Tim, Ellen, and Eve for the teamwork and for all the inspiring discussions. Let me start with a metaphor. As a doctor, I have always in my mind a picture of a patient surrounded by many professionals in separate buildings. One building for the GP, one for the medical specialist, and one for the pharmacist. The patient says, how can they work together if they don't learn together from one another? This is a metaphor of the silos the medical professionals work in without knowing much about what happens in the other silos. This is also the inspiration for my research about the collaboration of medical professionals who work in these different organizations and deliver mutual patient care. The main source of inspiration for my research is my work as a GP, where I meet patients with all different needs. But one common need is the need they all have for collaborating medical professionals who speak with one voice and the same language. For 10 years, I have acted as a medical coordinator, facilitating the intra-professional learning and collaboration between GPs and medical specialists, aiming at improving the transmural patient care. Now that we've looked at transmural care, care attuned to the needs of patients when they travel for their health between professionals of different organizations. The setting of this transmural care is nowadays more complex because of shorter stays in hospital, more elderly people with multimorbidity, and a growing amount of diagnostic and therapeutic possibilities. One doctor cannot oversee the whole scene on her own. And we looked at intra-professional collaboration, necessary for good transmural care. Patients expect their GP and treating specialist to be well informed about the other physician's medical treatment plan. The care and the collaboration both need medical professionals who dare to cross boundaries and change their habits and learn during this process of interaction with each other. These professionals change and rearrange their joint care, a kind of change laboratory process. Workplace learning. During these changes, workplace learning could happen. They learn about each other, what they didn't know before, and they create new knowledge. Learn what is not there, learn expansive. Arranging joint care responsibilities by making agreements between health professionals of different organizations is the main focus of my research. In the next few minutes, I would like to share with you my research on how I want to analyze this complex real world with the help of the activity theory, and to share with you the results so far. So let me move on to an outline of my research, which is still work in progress. First, our focus in this research process were our research questions. How do medical specialists, GPs, and their organizations arrange joint responsibilities when it come to patient care? What and how do they learn during this process? Second, we selected 2 regions within the Netherlands with which we could compare. One region with a coordinator center, A, it's named Zwolle, and one without, B, Alkmaar. A medical coordinating center is a very much Dutch concept and a kind of formal institute facilitating the joint care collaboration. The third step was both regions had to have one hospital, which most patients were referred. Let me take a look at the method we used. The study is a qualitative multi-case interview study done in 2 phases. In the first phase, members of different management boards were interviewed, from hospitals, medical specialists, and GP organizations. In the second phase, interviews with GPs and medical specialists were conducted. We selected participants using purposeful sampling and selected professionals from each region who had participated in making agreements on the process on how patient care is delivered. We also selected the professionals not involved in such a process. They could give us information about how well informed they were about the agreements made. Following the interviews, we performed a qualitative analysis of transcripts. We started with 11 interviews with administrative parties and have ended with 21 interviews with GPs and medical specialists, professionals, each with their own complex role in the patient care. So we had a lot of data. In order to structure and get grip on all these data, we applied the triangles of the activity theory. Using the triangles gave us the opportunity to look at an interaction between systems, boundary crossing, and within systems. All in all, we have identified 4 activity systems. In this way, each interview gives information about one or a few separate activity systems. One activity system we distinguish are the management activity system in each region. In this activity system, there were 3 different management boards: the management board of the hospital, the medical specialist board, and the board of the GP organization. In addition to the management activity system, we identified 2 activity systems for professionals, one for the GPs and one for the medical specialist. Besides all these activity systems, the MCC in region A, Zwolle, we mentioned earlier, was also identified as an activity system. However, in region B, without the MCC, there was an informal collaboration which we have yet to identify as an activity system. We developed the code tree using all the elements of the triangle. Identification of tensions and contradictions is an important part of the coding. Contradictions can arise both within an activity system as between systems. They may be the driving force behind change. Accordingly to these elements, we are analyzing the content of the interviews using a code tree where we classified text fragments. While our research is still in progress with coding and analyzing our data, I would like to show the results and findings about the substudy we conducted with a medical student with part of the interviews with the GPs. Let's look at the activity system of the GPs in more detail. We analyzed 9 interviews with GPs. 5 participated in the joint care agreements and 4 didn't participate. The Dutch name for the joint care agreement is a regional transmural agreement, the so-called RTAs. Now we come to the results of the GPs who didn't take part in the joint care agreements. First of all, we see the contradictions. In blue, the contradiction between the rules and the tools. The GPs mentioned they missed a tool for direct communication and blamed the General Data Protection Regulation with hindering this. And in green, between the tools and the object. And the object is making the agreements. The GPs describe the feeling of being overwhelmed by their busy daily care and all the changes in care distribution. They feel they are not prepared for these changes or that they had influence on this process. When we get a look to the outcomes, there are outcomes for professionals. What they say is when they see each other and meet each other, this part of the GPs see it mostly during when they have courses with each other. They say good communication and collaboration between GPs and medical specialists, knowledge of the other, personal and practical, and a strong GP identity. The outcomes for patients were consistent information and better care. Next, we come to the results of the GPs who participated in the joint care agreement process. There are also contradictions, and one contradiction is identical, and it's the contradiction between the rules and the tools. They blame the same general protection regulation in hindering easy digital communication. And the other contradiction between the rules and the community, which became vivid in the meetings with the medical specialist in creating the joint care agreement. They became aware of the different rules imposed by the health insurer for medical specialists and GPs, which hampered making collaborative agreements. When we look to the outcomes for the patients, these are more or less the same, besides one. The patient at the right time, in the right place, is mentioned more by these respondents. The other remarkable thing is that the GPs who are part of this process mentioned more and more they learn from each other. And another thing is they talk more about job satisfaction and flow in their work and a higher perceived decision latitude. So they feel they have more influence on their work and the work process. Highlighting some of the main points the activity theory brings in my research, it's very helpful to come to grips with a lot of data and provides a theoretical framework in analyzing contradiction and to make it visible. These contradictions may be the beginning of change and learning. And another main point is the insight in the differences in outcomes for professionals who participated compared to those who didn't participate in what they learn. And it also improved their job satisfaction, flow in their work, and their perceived decision latitude. This is the sub-part of my research. We are keen with working with the activity theory as a theoretical framework with all our interviews of all the 4 different activity systems and are eager to get the results. We are also working in another project about joint care collaboration agreement process in Region A. It's about heart failure, where different medical professionals discuss and change their actual collaboration. It's a kind of change laboratory without an intervening researcher, but there is a medical coordinator. This we will also analyze within the theoretical framework of the activity theory and change laboratory. We will focus on the learning visible in the way they talk with each other. I would like to finish with a summary of the main points of the use of the activity theory. It appears to be a very helpful framework to explore the complex reality of collaboration in healthcare. It provides frameworks for identifying bottlenecks and identifying where the contradiction lies. It provides a framework for thinking about where change is needed. In this way, it becomes clear which contradiction exists within one's own activity system and which exist in interaction with other systems. By talking about daily reality in this way and getting a picture of the activities of cooperating GPs and specialists, opportunities for insight and change are created. This opens different opportunities, especially when one takes part of such a project of lifelong learning for individuals, as well as its help to create a new common knowledge between professionals, their organizations and their processes, while changing the object and learning and creating what's not there, a challenging situation. Perhaps in the future it will be possible to demolish the walls between all the separate buildings in my metaphor. Who knows? My research with the use of the activity theory as a theoretical framework has sharpened my view on my daily work as a GP, as I became more sensitive to contradictions. As a result, I discover opportunities to change collaboration in patient care and to cross boundaries. So patients and professionals benefit from studying these collaborating processes with the activity theory. And now I would be very interested in hearing the feedback of Yrjö and questions of your all. Thank you.
Okay, thank you, Loes. First, I would like to ask the audience, the wisdom of the crowd, who recognize the problems of collaboration and communication between general practitioners and medical specialists. Those who recognize them very strongly just reach very high, and just think that, it's mildly, there might be something, something problematic in between, so go a bit slower. So good vote now. Right, so there are many people who recognize this is not only a problem in the Netherlands, it's a problem throughout the world, and it's very important work Loes is doing. Okay, would you, Yrjö, like to say something about Loes's work? Yeah.
Supposed to come from the audience. Please.
Yeah, well, I would like people to go up and, yeah, right. Perhaps we ask first the audience and the online audience as well, because I know, right? So I should have brought binoculars because my sight is very bad, but I think there is somebody behind the microphone 7, is there? No. He's escaping. No, somebody, right, 3, go ahead, yeah. And introduce yourself and tell us, where do you come from?
So I'm Claire Morris from the UK, and thank you very much for that. It's very dear to my heart. I'm curious to know how you made the decision about what constituted an activity system during your analysis, because you said there was one you weren't sure yet if it was a system, so I'm curious to unpack what to you constitutes an activity system in the context of your work.
Yes, I've always been interested in the activity system of the general practitioners and the medical specialists, and I've been a medical coordinator. That's why I'm interested in a region where an MCC is and where not an MCC is, because everyone thinks collaborating go by heart and it happens, but when you do nothing, it has to be activated, and also when there is some collaboration and between 2 people, it's not the whole group can do it. So the medical coordinating center can help to focus, write it down, and to make the process more clear. It's like a researcher in a change lab process.
Okay.
Is that?
Sort of, I'm just wondering if you defined it by, if there's a shared object, you're looking at who contributes to the object, and
yes,
therefore that makes it the system. Because you said on one of them you're not sure yet if it is.
Now, the shared object is making agreement.
Yeah, okay. Thank you.
That's the thing you...
Yes, sort of. Thank
Sort
you.
of, okay.
I've got an idea now.
Okay.
Okay. Right, and there's somebody on a microphone 2. Please go ahead and introduce yourself.
Yes, so my name is Nicolas Fernandez. I'm from Montreal, Quebec. I work at the Faculty of Medicine of the Université de Montréal. And we have a privileged position of being both in the English world and the French-speaking world. And we are currently working with La Clinique de l'Activité, a French version of the application of activity theory, stemming from the CNAM, the Conservatoire National des Arts et Métiers in Paris, France. And this methodology is very much inspired by the same grounding as this activity theory. And I'm very curious to see the differences between the activity theory framework as developed by people in Finland and then as developed by the people in France. So my question to Dr. Meijer, you've reunited all these different perspectives with regard to the same object. I'm wondering first of all, how do you intend to translate all that new knowledge that was gained from this process? How is this going to make a difference for the people on the ground eventually? I mean, you've managed to identify certain issues, certain tensions and contradictions. How do you see the future now? What is that information going to be used for, and how will it eventually impact change? And also, I noticed that one important player in your activity model is missing, the patient. The patient also shares an object, and in many ways, if you look at the silos, the only person that really reunites all those silos is the patient. So, how do you intend to integrate eventually patient voice into this?
Yes.
Thank you.
Yeah, sometimes it's difficult to start with your last question, where you can put the patients, because it's not so easy to get them part of the whole process, because there are patients who have not the ability to sit with so many doctors, and it's quite an amazing existence. As a GP, I hear how patients feel our communication and how it works. Sometimes I can declare the things the patients feel, but it's a struggle to have a look from how can we get information from patients.
Have you any patients involved in the setting? I mean, do you have, if you organize Change Lab, do you have patients involved? There are two questions, but you just say yes or no.
We haven't involved the patients there.
Okay.
Yes. And the other question was about the...
I think we have two questions. There were so
Okay.
many questions.
Okay.
In one, I love the comment and about the kind of collaboration and communication between two different language groups. But I think we have a couple of questions. I would like to take them. So there's this lady is in the center. Yes, I don't know. Okay, lady number 4.
Good morning. Yeah, I'm from the Philippines. I'm Dr. Sosa. And my concern is about when to start collaboration. For us, we felt that at the student level, it should have been started. We have to start our students, and they should be prepared, collaborative ready practice. So I don't know if you can answer if anybody in your team can answer the question as regards to when is the best time for us to start teaching them. Medical student collaborating with a nurse, collaborating with the other healthcare professionals, because at the end of the day, it's going to be the team that's going to be very helpful in providing quality care for our patients.
Yes? Okay. Yes, I think it's good to start from the scratch. So when people are joining the other professions, but later on, another part of my work is arranging joint education for trainees GPs and trainees medical specialists. And then I take patients on paper, and they have to discuss what can you do, what can the other do, and it helps to get insight in all the things other can do, and where the restrictions of your profession is. And it's very, very necessary to help each other. And it's also, it helps enormous when there are very difficult tasks with people who don't know what they are doing and are angry. And sometimes with all of us, we can do the good, but maybe a little best.
Yeah. I think okay, we have one question there and one question there. Quite short questions, please. Right, number 7, lady number 7, they're in lovely red jackets.
Thank you. I really enjoyed your presentation and really learned new about your active theory model. My question is, there's a lot of literature coming out now from the clinical translation science researcher on science of team science. And my question to you is, in your research, have you involved what the science of team science talks about breaking the collaboration silos through the science?
Yes, the people say about breaking the silos. One medical specialist says, in the region where there's no medical coordinating center, we need special doctors or professions who bring us together. Without these people, it won't work. So in my interviews, many people say we work our individual work, but it's necessary, there is time, there is space, and there are people who arrange our collaboration.
Okay, and the last question goes to lady number 4 with, yeah, right, over there.
Okay, my name is Yrjö from the Netherlands. Thank you, Loes, for your presentation. I do a lot of research of teamwork, and one of my learning lessons was be an expert before you go to the other. We have found something in your data by analyzing with the activity theory about the teamwork to separate your own expertise and then to go to the other?
Yes. You mean what's the good moment to collaborate? You must first know your own knowledge of your profession, but it's very necessary to do it more earlier, because all the specialization are without doing things together. They do it all apart, and when they do for the undergraduate things together, but thereafter it stops. And I think that's the moment it's necessary to work together. And yeah, okay.
Okay, no, sorry. No, but I think our time is running out, so I just gave the microphone to Yrjö, who is going to give,
Just a
yeah.
couple of additional questions. A lot of very interesting points have been taken up already. One of you pointed out that in the field of activity systems described by Loes, there was not an activity system for the patient. And I also wondered about that, and I think the question is, what does the joint care agreement mean for the patient? Is the patient actually party to that agreement? And if so, it seems that it might be, you might consider it useful to also put the patient in the picture and to consider what is the meaning of this for the patient. So that's one thing. The other one is that I think that the very agreement itself, how it looks like, what is the shape of this agreement, how was it worked out, who initiates the agreement, and how is it used in practice is extremely interesting. So I would like to, have a lot of more concrete stuff about the agreement itself. Yes. Thanks.
Okay. Thank you, Loes. I also learned to pronounce her name. Do I do it correctly? Loes Meijer. Loes Meijer, Utrecht. I try to learn all languages. Is it Utrecht? Utrecht? Okay, right. So now finally learn to say it properly. Right, thank you so much. And I think it's a very important comment because look, it's work in progress. So you are going to, really consider them when you proceed, won't you? Lovely. Thank you for the audience, and we move onwards. Now I'd like to invite Professor Tim Dornan to present his work.
Eeva, Yrjö, ladies and gentlemen, I'd like to draw your attention to the two names after mine on this slide. One of them is Hannah Gillespie, who was a medical student at the start of this work, is now a junior resident and has supervised me very skillfully throughout this work. The other is Neil Kennedy, who is the inspirational head of the undergraduate medical programme in Northern Ireland, who's been a constant source of encouragement for us to trouble the system. The aim of this presentation is to show how activity theory shapes change and how students learn medicine with and from real patients in clinical practice. The central assumptions, quoting Yrjö, are that what more than anything else arouses involvement, effort, emotion, excitement and frustration among frontline staff is encounters with real live patients, which defines patients in activity theory terms as the object of medical education. And quoting from Alan Bleakley's work, medical education for the future should centre on close reading of the patient. Now, my evidence that the object is out of focus is illustrated in this newspaper cutting, which is almost exactly 10 years ago, when, as the principal author of the EQUIP study, I was projected to stardom in the UK. This is from the Guardian newspaper, and I was on the Radio 4 programme, Today programme, which means you've arrived. And the work commissioned by the GMC, the UK regulator, showed that junior doctors make errors in 8% of prescriptions, 5% of which had potentially serious consequences. So I'd like to suggest to you, ladies and gentlemen, that at the most basic level, the object is out of focus. Things are in a bit of a mess. Now, I like messes, and I was a diabetologist, so I have now focused my attention on about the biggest mess it's possible to find in the clinical world, and that is the treatment of diabetic patients in hospital with insulin. I'm going to show you some data to show just how big a mess can be in the world of medical education. Junior residents, according to our EQUIP study, write 70 to 80% of insulin prescriptions for all patients in UK hospitals, and it's usually the more junior, the first-year residents. Now, there's something called the UK National Diabetes Inpatient Audit, which shows that the proportion of these prescriptions that have errors is something like 5 times higher than the average. That 3 out of 7 hospital days are affected by hypo and or hyperglycemia, and shockingly, 1 in 25 patients on insulin in a UK hospital goes into a hyperglycemic state, which is potentially fatal, after admission. And there is also data to show that doctors both over and under involve patients in their own care, so people don't seem to know how to strike any sort of a balance. And that the really important thing is that this is a serial study which shows little, if any, improvement. That's a mess. Now, the next issue I'm going to address is that this is not simple, and much of what is being done in the name of patient safety is predicated on assumptions of simplicity. And I'm going to read from the EQUIP study one of the residents describing how they made a prescribing error. The registrar came, reviewed the patient and said, no, we should give Tazocin penicillin. By that stage, I'd forgotten that the patient was allergic to penicillin, so I prescribed penicillin without thinking. I say without thinking because I had thought of it, but I suppose it was because of the security of thinking, gosh, someone's finally come to help me with this patient. I just kind of did it, and so basically the resident prescribed penicillin for a penicillin allergic patient. But the key thing is they converted a correct action into an incorrect one, and that is my evidence that things are not simple. Now, the conclusion of EQUIP was that the intervention that was most likely to prescribing safety was greater familiarity with the social complexity of clinical workplaces, which, to me, invites research using activity theory. Now, I have, over the time since then, focused on causes of the mess in prescribing, and we have a regional project which I lead called the Making Insulin Safer Project. I'm not going to say a lot about this, but it's produced very rich data about why this mess exists. Now, let's just go back to basic physiological principles. If you think of insulin, it has a half-life of about 13 minutes in blood. It has a narrow therapeutic window. It's finely balanced against the level of blood glucose, which is, of course, influenced by eating and exercise. Eating puts it up, exercise puts it down. People with diabetes on insulin manage this extremely well when they're out and about, by and large. But when they get admitted to hospital, everything changes. Because now there is a pathological problem wrapped around the outside of the physiological problem. Because now they're not active as they would be when they're out and about. Other diseases may make their blood sugar go high or low or oscillate between the two. That a lot of patients in hospital have problems with their gut, so they can't absorb nutrients in the normal way. And treatment can actually cause the blood glucose level to oscillate unless it's prescribed with very careful anticipation. Now, the thing that least attention is paid to when we talk about clinical uncertainty is the next layer, which is the social problem, and this absolutely dominates residents' experiences of practice. And there's loads and loads of categories that they feel unprepared. There's work intensity disruption. There is a systematic phobia that exists that if you bring somebody's blood glucose down to normal, it'll go too low. That there's a culture of getting by copying, social isolation, and so on and so on and so on. So now we have this awful situation, but then we have another layer again, which is the emotional problem. And that particularly since the patient safety movement came along, junior doctors live in fear of their lives of making a mistake. So that actually trying to navigate this complex situation, it can lead to positive emotions if people manage to hack the problem and get through okay, but it can cause fear, anxiety, vulnerability, indecision, inaction, and discord. And in fact, one of the most common things we find is that junior residents face this appalling complex task, simply play for time, defer to the next shift, and copy what the last person did. Now, I would like to suggest to you that negative emotions should be a cause of concern to us given the problems we have with burnout, and that medicine is becoming a much less attractive career, and in the UK we're hurtling towards a workforce crisis. Now, let's think about how to solve this problem of the object being out of focus. And here I quote from Mencken, who said, "There's always a well-known solution to every human problem, neat, plausible, and wrong." And I'm going to return to the graph which Yrjö showed in his presentation, with the vertical axis with the collective and individual locus of expertise, the horizontal one between learning stability and learning for change. And I think I'm using his words when I say that the right-hand quadrant is characterized by high flexibility and ability to change, and that you enable people to do this by stretching them in supportive learning environments. And the reason I like insulin is because there is no other way to learn to do this in fast-changing clinical situations other than being stretched in supportive learning environments. The bottom left-hand corner is low flexibility and ability to change, which is characterized by the currently dominant paradigm of training and testing. Now, the significance of this slide is that the patient safety movement has acted as an attractor to bring medical education into the bottom left-hand corner so that people's competence can be tested in order that they can enter practice as safe practitioners. But herein lies an inherent contradiction. And if you think I'm making this up for theatrical effect, I will now show you some evidence for this. Now, you are now becoming familiar with the activity system triangle. I've actually used T for tools at the top because tools rhymes with rules in the bottom left-hand corner, which makes it a little bit easier, and then DOL, division of labour. But if we start off with the assumption, which I think pretty well any practitioner would agree with, that things inspires and motivates us, the object of our activity is the patient, and that activity should lead to expertise. And the way we gain expertise is by things that are instrumental in our learning of different practice contexts, different clinical situations, different practices. The rules are rules of involvement, supervision, delegation, help seeking. The community is many different professionals and patients, and the division of labour is dictated by practice in a very fluid way. Now, the regulator's response to the problem of insulin safety following the publication of the EQUIP study was surprising because it introduced a national high-stakes assessment located in the bottom left-hand corner of Yrjö's quadrant, which is called the Prescribing Safety Assessment. Now, this is a very different activity system because the object is to pass the PSA because you won't have a livelihood unless you do, and the outcome of that is not expertise but competence. The tools are computers, books, test questions. The rules are to anticipate what questions you might be asked and to learn the answers. The division of labour is joining with your peer group to try and get through this high-stakes assessment and engaging teachers as you can. But very dominant in this system is the regulator who is wanting to regulate in order to bring practice in the bottom left-hand corner for the sake of patient safety. Now, you will say this is extremely unfair of me, because in fact medical schools also introduce periods of shadowing before they enter practice. But the shocking thing we found in Northern Ireland is that whilst the ideal of those experiences is that they are different from a doctor only in that they're in a doctor-to-be, if you look at the subject, what we actually found was that the reality of these assistantship periods, which did not have high-stakes assessments, was that students had really lost sight of the object of the patient as the inspiration and the motivation in the messy world of practice. So the only figure they could really see, the only reason for doing anything was to satisfy the regulator, and in order to do that, they needed a signature on a piece of paper. And we found that certainly some students, just before they started residency, could do nothing more than get a piece of paper signed and go home. So let's go back to the ideal of the assistantship, where the subject is doctor-to-be, and otherwise this is the same as the activity system of practice. But in the bottom right-hand corner, we have a clinical role, which is, of course, that which enables you to transition into practice. Now, we adopted an intervention which I first encountered in Edinburgh. Sam Smith did a doctorate on this, supervised by Helen Cameron. Beautiful work. Published later in BMJ Open. And in Keele University, Andy Hassel and Ruth Kinson have, at scale, got all of the students getting loads of experience of writing medication orders for patients before they qualify. And the way they do that, I'll illustrate the way we did it, which was lifted pretty well straight from Keele. I'll give you an illustration of how this is done. Now, the student's task is to write a medication order on behalf of the patient and team. In order for us to get permission to do this, we actually had to go to the regional seat of government and present the case to the chief medical officer, the chief pharmaceutical officer, and the medical directors of all of the trusts in Northern Ireland. But it's a can-do place, and we emerged 30 minutes later with the mandate to go ahead and do this. So the way that this is done is extraordinarily simple. In the UK, we still write, or in parts of the, in Northern Ireland, we still write medication orders pen on paper. So that we gave every student 2 or 3 purple pens. We introduced an operating policy which was agreed between the trusts, and their task was to write a prescription and do everything but sign it. What then happened was it was the responsibility of the student to get the prescription countersigned or to delete it. Now, if you think of this in patient safety terms, far from students actually making practice more dangerous, they're making it safer because it introduces a check-in system and integrates education with that. And so the patient is the object, the student has a role within the activity system, and that patient, pharmacist, nurse, resident are the community of practice that support the student's engagement in practice. Now, I've offered you this one example because to me it's a very attractive one and it's been surprisingly easy to introduce, but I would draw your attention to AMEE Guide number 129, which is being launched at this meeting, which I have first authored with the team from Belfast. And we've got copious examples of extremely innovative practice from all around the world, where people have found absolutely brilliant ways of getting students focused on the object. So, just as some evidence in the case of the Purple Pen Initiative, students' narrative descriptions of their learning show, I learned by admitting patients, I was able to check their medications, staff actively encouraged me, patients, residents and pharmacists guided me, I learned from the ever-changing, not the stable environment, and when I asked questions I always got more information than expected and it really helped. Now, I'm getting towards the end, and I'm quoting Yrjö again, and he used some of these same words to describe not working, and very nicely said that it means working in knots. And that I would suggest to you, ladies and gentlemen, that if we really want safe practice, students need to learn rapidly pulsating, distributed and partially improvised orchestration of a collaborative performance amongst otherwise loosely connected actors for whom patients arouse involvement, effort, emotion, excitement, and of course, sometimes frustration. Now, this is a coda to my presentation. And it's one of Aesop's fables, which many of you will know. And this is the fable about the sun and the wind having an argument as to which of them was the stronger. And the wind claimed that it was extremely powerful. The sun said, well, let's just see about this. Now, a man walked along, and they agreed that they would put this to the test and see which of them could get the man to take his coat off first. So the wind blew and blew and blew and blew, and the man simply buttoned his coat up and walked on. So eventually the wind was exhausted, and then it was the sun's turn. He smiled, and the man took his coat off. Now, if we come back to patient safety, the regulatory wind has blown and blown and blown, and it's blowing brilliant young members of our workforce out of medicine. Could I invite you to embrace what Yrjö said this morning, what Ray Land said last night, and could we all share in the common world of uncertainty and indeterminacy and make this a collaborative exercise, and that's the way we'll improve patient safety. Thank you for your attention.
Thank you, Tim. Very powerful presentation and lovely ending. Yes. Okay, are there any questions in the audience? Would you please go to the microphone?
Hello, I'm Richard Ayres. I'm from Plymouth Peninsula Medical School, but I'm also a GP in Plymouth City. So thank you so much for that, Tim. There's a big trend, as you have mentioned, towards patient safety. And it is leading, I quite agree, in the directions that you highlight. There's also another new trend called shared decision making. And it amazes me as a GP that patients who are, for example, in this case diabetic, are admitted to hospital, they have their clothes removed, and they also have their decision making removed. These are people who've looked after their insulin often for years. They know loads more about it than most of the doctors on the ward. And the first thing we do is remove the decision-making over their insulin from them, give it to some junior doctor who hasn't got a clue quite often what to do, and as you say, is terrified of the whole process. So I'm interested to know whether it would be, rather than whether we could have the student, with the purple pen and so on, but coming up to the patient and coming up with a shared decision. They know what to do about their insulin.
Thank you.
And that could then be presented to the senior doctor.
Eva, although Richard and I know one another well, he's not a plant. But I would like to take you back to the Making Insulin Treatment Safer project. And we've put patient involvement at the point of making prescribing decisions a central plank in this. Now, I can't say much about this because this is different from what I spoke about. But we've put together all of the evidence about decision-making in indeterminate situations, and we've developed this acronym, SMAC squared, which stands for the situation, myself, act, check, and check again. And the situation, the first question is, what is the patient's need, and how would they like to be involved in this decision? We've conducted those debriefs that I told you about, 113 junior doctors. We've found that this has produced quite a strong discourse of patient involvement. At the outset of the project, people were very afraid they would be criticised for taking patients' advice. So it's a work in progress. And I think it's actually very difficult to do when the culture is paternalistic in the way you describe. But thank you very much for your question.
Thank you. And I think the lady behind the microphone 3 was before you back there on microphone 7. So go ahead.
Okay, so Claire Morris again from the UK. Methodological question for you, Tim, unsurprisingly. At what point did you decide to put the tools of activity theory to use in your work? So did you set out theorising using activity theory, or has it been an adjunct to your analysis?
Yes.
And linked to that, what did it reveal that other methods might not have revealed to you in your work?
Thank you very much indeed. I think the thing that absolutely grabbed my attention was when I saw the way the purple pen had acted as a mediating artifact and had brought about an extraordinary change. And in fact, I mean, I don't know whether Andy Hassel is here and Ruth Kinson who did this, but they did something extraordinarily courageous, which is when a student wrote a prescription under the radar that caused harm, they brought prescribing by students onto the radar by using a mediating artifact. So from the moment I heard this notion, I'd love to hear Yrjö may have things to say about this, this just really grabbed my attention. Now, in fact, what actually happened, because in the real world, we came out of Stormont, which is the parliament in Northern Ireland, and Neil, my boss, said to Hannah and I, do it. And 6 months later, it was done. And so I think that if you looked at the way it was done, it would have many of these factors. I mean, for example, the fact that there was a junior resident who really knew what it was like for students because she just graduated, that she had a remarkable capacity to galvanize, and she was a very good advocate. So I think it maps to activity theory, but I think it'll probably be very helpful for the ongoing process of change. But I mean, gosh, I'd love to hear what Yrjö has to say about that.
Okay.
Does that answer your question, Claire?
Thank you.
Yeah.
Okay, number 7 there, back.
Hello, I'm Jeff Wiseman from Montreal, McGill University Institute for Health Sciences Education. Tim, thank you for a wonderful presentation. I have a question. There's something that's in my mind that I have to get out. The first presentation in yours, all comment on time. Lack of time, playing for time, no time for GPs to, in their busy practices, to communicate. And my question is, how is time encoded in activity theory?
Could I possibly ask Yrjö if he would, but could I just for a moment, I would like to respond to that, because one of the things that quite shocked me as a clinical educator was that within a month of entering clerkship, students in Manchester where I worked were socialised into saying they hadn't time to speak to patients. So I think the point about time is extremely important, but I think that if, Yrjö, would it be all right to hold that over to...
Yeah. Okay,
I'll take that as yes, because... but thank you very much for the question.
Thank you.
Would you like to comment now on the time constraint?
I was supposed to ask questions. But it is indeed a crucial issue, and when we think about expansion of the object as the foundational challenge for activity theory, usually we look at it at least in terms of expansion in time and expansion in space or social space. In other words, meaning that you need to involve both longer time perspective, but also a more let's say, multiple time perspectives. You need to be able to shift between short and long-term perspectives on one hand. And this means that the reconceptualization of time is a very crucial aspect of expansive learning. Typically, you often find out that the lack of time is one of the most persistent myths which is used as a sort of buffer against reconceptualization of the work. There's never enough time. There's never enough time. But you need to tackle that very, very concretely and open up the time dimension and what is actually going on. Commonly, that means that, you know, some dear, let's say, prejudices about time are challenged when you engage in this type of formative interventions.
Okay, and the last question goes for you behind Okay, sorry, so they were first, sorry. So I have to say sorry, but you might ask it later on. Okay, number one.
Hi, Mark Goldschmidt from Centre of Education Research and Innovation at the University of Western Ontario in Canada. Tim, that was great. As you know, and maybe many in the room do as well, in Canada we've actually had our students doing these types of orders for quite some time now.
Yes.
The challenge as you move that forward, though, is there are so many other material forces at play shaping the safety of that activity. What we've begun to see as electronic records become part of that system, where a student can recommend an order and then it has to be co-signed by a senior resident or by their attending physician, is that they start to build up. So all of a sudden you have 10 orders to co-sign or 20 orders to co-sign, and all of a sudden that system now starts to change where the focus and the object of the activity is getting the work done. And then the attention to the detail and the double check, the lack of physical presence of the two people at the same time of the cosign, all come into play, which potentially makes it unsafe as people sign multiple orders all at once. And I'm just wondering if you've thought about that as you move forward with the activity theory perspective of the research.
Mark, thank you very much indeed. I have observed students in your hospital working and learnt a very great deal by doing that. I think that one of the things I learned from AMEE Guide 129 was that we made inquiries from people all over the world about how students are engaged in practice. And Canada, I would say, is the extreme case of students remaining integral to the process of care. And I suppose it does raise the question about whether students can become too integral to care. I think that what our experience thus far, and again, if somebody from Keele University or Edinburgh was here, they'd have something more to say about this, but I think retaining the student's position as a boundary crosser and doing a supervised proportion of work extremely well probably at least breaks even in terms of time.
And now I'm approaching Tim as
yellow an orange ghost.
Orange ghost,
yes.
because the time is out. I leave the last word to Yrjö. Okay.
Just one point, and I would like to connect back to the purple pen. I think very importantly, you pointed out that the emotional, basically the fear among the students or novice practitioners is a key factor here, and fear paralyzes. In activity theory, there is a very important sort of direction of research on a mechanism that Vygotsky discovered, which is called double stimulation, which is specifically an issue of how people can overcome paralyzing conflicts of motives. And typically, what you need in those kinds of situations is some sort of a second stimulus, as Vygotsky called it. And I think that the purple pen sounds like a textbook example of that. And I would really like to have a very careful, detailed study of the purple pen. And in the perspective of double stimulation.
You're on.
I certainly will bug you about that.
All right, thank you all. Thank you, Tim, for a lovely presentation. I'm sorry we have to move onwards. And our last presenter is Alan Bleakley. I would like you to come here and start your presentation of the good intention of poor pedagogy.
Thank you, Eeva. Thank you for turning up and staying on. Difficulty with being the third speaker is you're pretty tired by now, so please take a breath and re-engage. I just want to say thank you to my colleagues here. You don't know in the audience, the email trail for doing this particular session is about an 8,000 word document, which should be published. And that's the kind of work, as you know, that goes on in the background to these presentations. And these have been terrific colleagues to work with, and it's illuminated my understanding of how activity theory can be used. I'm going to turn a sort of sharp corner and show you how activity theory can be used in a pedagogical way with a medicine curriculum. So I want to say thank you to Yrjö for inspiring this work again, and to draw attention to his new book on expertise in expansive learning in medical work. And also to just flag up that the beauty of this work for me is that it raises not instrumental questions particularly, but aesthetic and political questions. And they, in turn, embed themselves in ethical questions. I think one of the things that we miss in medical education is the beauty of the work that we do, the aesthetic of the work that we do. So my interest has been in bringing that to students through the medical humanities. And the medical humanities, as you'll see, have become central to a curriculum that I've been involved in ever since 2000, although the first students came to us in 2002, when we planned a new school called the Peninsular Medical School. Richard has already, in his question, referred to Plymouth University Peninsula. That's a separate school which came about with a division between the universities of Exeter and the University of Plymouth when they fell out, which is all due to the antics of vice-chancellors and their egos and the rest of it. But now we have two separate medical schools when we had a divorce in 2013. So the period that I'm looking at is between 2000, when we started to plan the Peninsula curriculum, and 2010, when the whole thing was rolling. And I'm doing this as a retrospective experiment, looking back on that and thinking to myself, how did we as a team, and myself as an individual, use activity theory to shape that curriculum? So the very first thing that we did was to say, what's wrong with the undergraduate medicine curriculum? What's wrong with medicine itself? What's wrong with medical culture? Well, the thing that's wrong with medical culture is that it eats its young. It eats its young alive. It ingests its young like Saturn or Kronos, and keeps them in its belly and makes sure that they don't have any ideas between them, but they reproduce what has gone on before. That's very harsh, but that's obviously being rhetorical about the whole process of medical education, because the traditions that you have to keep up are the traditions of patriarchy, paternalism, heroic individualism, autocracy, and hierarchies. And we wanted to challenge that with our curriculum. We wanted to challenge it too because we knew the evidence base up to that point, up to 2010, showed that students show cognitive empathy decline very quickly into their studies. By the third, fourth, and fifth years, they have fairly high, relatively high cognitive empathy decline. They also have emotional detachment and insulation setting in, emotional insulation, in which they're separating themselves from and objectifying patients. They have growing cynicism. A result of that, which alludes to Tim's talk, is that medical error is a potential of that medical education process because of the way that we teach students communication. The whole business of teaching students communication in simulated settings and through communication skills, so-called, is absolutely ridiculous. And I've written a lot about that, and I'm sure a lot of people in the audience also share that with me. It's a ridiculous process. As human beings, we can already communicate, and to learn to communicate professionally in a medical setting doesn't require too much of a shift. And what we do is we squeeze out the natural communication abilities of students by professionalizing them. I'd like a question on that later. And the fourth thing, which is often forgotten, of course, is that doctors don't look after themselves well. So how do we teach our medical students to start to look after their emotional states, their psychological states, and what support do we provide for that? So this is the background to trying to develop a curriculum. And as we thought about this and thought about the theoretical background that we might engage with in order to plan this curriculum, we said to ourselves, well, let's have three legs to the stool of the curriculum. The first leg is that we will do clinical and communication skills through giving the students the opportunity for early and sustained work-based learning, but also doing things like teaching anatomy through living and surface anatomy and not through cadaver dissection. We want to do our anatomy and biomedical science in a different way. We want students to think about their biomedical science as intrinsically beautiful, as intrinsically engaging and intrinsically aesthetic, and not just instrumental. So the way we wanted to get a conversation going between those two areas, between the classroom activities and the clinical activities, was to have a third place through which students could think otherwise about their studies. And that thinking otherwise, we decided we would do through the medical humanities and ethics. So we had an integrated core provision of the medical humanities, which filtered through all of the work that people did and the way that they thought about their medicine and came down to the students. So the first thing about that, and if any of you are thinking of, are engaged in planning a new medical school, the thing about that is the curriculum changes through engaging with faculty. The students will often just fall into place with whatever is going on, but the faculty have to be changed. So the very first thing we did as people who were committed to the medical humanities and to ethics was to go to the science faculty and talk to them about the way that they were going to teach science and the facilitative settings that they would give for students to learn science. And we said, is this going to engage beauty? Is this going to engage form? Is this going to engage performativity? Because if it's flat and instrumental, it will not engage the medical humanities. So the science faculty got on board with that. And then the social science faculty got on board, and so on and so forth, until we brought the whole faculty in to think through the medical humanities about their work. But we had a pedagogical model that drove all of this. The driving model was activity theory, which you'll see from the subsequent slides. So the way in which I and my colleagues introduced activity theory into this thinking, and the way in which we've reflected on it since, is the beauty of activity theory is that it goes to the environment first and then looks back on the individual. It goes to the object as the focus of study, and it looks back on the individual and looks at how subjectivities are then built up through complex environmental concerns. So as the object of study expands, so it speaks back to and shapes the subjects and shapes the subjectivities and the identities of the people who are engaged in that environment. And we thought about calling that environment a creative knowledge environment, an educational climate, and ultimately it's an environment that is focused on patients, of course, which we've seen from all the other presentations. So here's the classic triangle again, and this is a way in which this might be represented in a formal study. But as we look back on this and as we thought about it, and we looked at the glitches that happen in curriculum planning in medical schools generally, we thought about the artifacts that we're using and the way that the students would engage with those artifacts, and we saw a difficulty, a contradiction. And we wanted to use that contradiction wisely to employ it in an educational process. And that contradiction is this. If you cast your ideas to the bottom of the slide, the first patient that is met, certainly in North American and Canadian medical schools, is dead. The second patient that you meet is deader. A white male sim man. The third patient that you meet is in a bed and alive, but you're not allowed to touch her. You're not allowed to engage with her because technology intervenes. So your three levels of patients are already objectified for you, and you then walk into that hall of mirrors and you engage with it, and it shapes your identity. It speaks back to you. So we thought we have to change these artifacts, because this is what the artifacts do. They turn the object into abjection. If you're learning your anatomy through cadaver dissection, and you're meeting death for the first time, and you're meeting illness in a serious way, medical students have to learn to deal with the abject. The abject is about disgust. What do you do with that disgust? What we don't teach medical students to do is to deal with the repression of that abjection, which comes out later in a distorted form as burnout. The symptoms of anxiety, depression, alcohol and drug abuse, and burnout. So we have to look, and we're in the city of Freud, we have to look at the return of the repressed. Please go to Freud's house. It's not actually open at the moment. They've switched it to a house next door. But go to the Freud Museum, get on your knees and say, thank you, Freud, for teaching us about medical education. Because the one thing we need to know is how to deal with the return of the repressed emotional conditions that students have to deal with when they meet those three patients: the dead patient, the sim man, and the patient in the bed who you're not allowed to talk to. So let's go to this model. This is just such a beautiful and elegant model, and recapture what I've just said. Here's the traditional medical education curriculum, stuffed into tradition and the will to stability, and kept down into an individual locus of expertise. You will be the heroic individual. You will grow up as a heroic doctor, but you will learn by being eaten alive by your parents, particularly the father, because the father is medical culture. We want to change that. We want to get into innovation and move over to possibility knowledge and a collective locus of expertise. Now, how do we do that? What we thought about in our curriculum was the object and the purpose of the curriculum is, first of all, to democratize medicine itself. This is a long-term horizon project, which I've written about now for well over 20 years. How do we democratize medicine? More importantly now, in the Me Too movement, how do we feminize medicine? And even more important, how do we bring tender-mindedness, the beauty and the form that I talked about, and the aesthetic and the ethical questions? So this is William James' idea of a tender-minded versus a tough-minded attitude. Medicine has been stuck, medical education has been stuck in tough-mindedness, which is pessimistic and leads to cynicism. The optimistic, tender-minded view leads to a much more open account, but also a way of dealing with medicine which opens up dealing with uncertainty and ambiguity. So in activity theory terms, as Professor Engeström has shown so wisely, we can talk about these as medical humanities spearheads. And these form a zone of proximal development. This is the zone, the indeterminate and the expansive zone in which we will place ourselves to talk back to the individuals who are developing themselves as doctors. This is the zone we must sit in terms of curriculum studies. So we'll run through this again, looking at it a little bit differently, and I'll run through these slides rather quickly. The very first thing that we must do then is, while our patient and our patient care and our patient safety is the object of the work, now in medical education the object of the work too is to educate the sensibility and sensitivity of students, because what we are doing at the moment is educating for insensibility and insensitivity. So we must draw ourselves back to this object. The medical students' identities will then change and be more open and be more tolerant of ambiguity. How do we do this? We work with a whole new set of artifacts which leads us away from these three patients: the dead, the sim man, and the patient in the bed. We fine-tune this. For example, at Peninsula, we developed a whole way of working with anatomy, which was to use artist models, for example, doing surface and living anatomy, watching a person move, drawing the body, not getting into the Foucauldian medical gaze of looking into the body, but being with the body of the person, not the patient, the person, and collaborating with that body. We wanted to form a community in which democratization, feminization, and tender-mindedness were just accepted as core values. And that is the medical humanities. That's the medical humanities as a curriculum climate. The people we drew on were people like Martha Nussbaum, talking about how the humanities promote democracy. So learning about the humanities brings democracy. Mark Sluka, the humanities are a superb delivery mechanism for what we might call democratic values. So by getting people to not just read, but act and act into humane ways through the arts and humanities, and to express themselves and think otherwise through that, we're getting them into a democratic, a feminizing, and a tender-minded mindset. We wanted them to read feminists. We wanted them to read people like Hélène Cixous, because her work is both political and about the woman's body, but also about feminizing the body of cultures. We wanted students to consider a phrase from Zixu like, what is it to write with mother's milk? What is it to write a prescription with mother's milk? Because that prescription is nourishing. It's not instrumentalizing in the way that Tim pointed out, using the prescription unwisely to objectify a patient and maybe to make a mistake. Writing with mother's milk. What if we wrote our medical education with mother's milk so that it was nourishing? And what if we turned to lyricism instead of the epic, the tragic, and the dark comic? No more behind-the-scenes black jokes about patients. No more big stories of death. No more narratives about tragedy, but lyricism, beauty, and form. And does this work? I'm not going to linger on this slide. Take it from me that it does work. I meet our graduates quite often, and they turn out to be rather beautiful and interesting doctors. Thank you very much.
Thank you, Alan. Would you please stay there? I know Alan was the first one who sent his presentation, and I was kind of, wow. Right, but now we have some questions from the audience. Number 3.
Hello, my name is Agnes Elmberger. I'm from the Karolinska Institutet in Sweden. Thank you for a very interesting talk, Alan. I have a methodological question, maybe to all of you, so we'll see who feels most inclined to answer. So before Claire Morris here asked him what activity theory highlights, and my question is the opposite. So as Kenneth Borg has said, every way of seeing is a way of not seeing. So in your experiences, what is it that activity theory does not see, or what is left in the periphery when you use this theory?
Yeah. So the question is, what does activity theory not see, and what is in the shadows? What does it hide? So another way of looking at this is, what does activity theory repress? Well, I think an easy way to answer this is, does activity theory look at itself reflexively? So if you think about activity theory as an activity, does activity theory look at its own activity and ask questions about it? I mean, my concern with activity theory over the years has been with the triangles. You know, graphically, the triangles don't work. Everybody who works in activity theory knows that those triangles are metaphors. And yet, when you talk to people about them, they struggle with the whole thing of reducing human fleshy contact into that particular pictorial form. So I think what activity theory might hide from itself is A, a concern with its own activities, and B, a concern with its reductionism.
Thank you.
Yep.
And now there's an online question.
Yes, thank you. So I have a question from the live audience who's watching our symposium. And the question on activity theory is about the limits of the interview-based methods. It can be answered by any member of the panel. So why or why not to complement interviews with observation?
Can you, why or why not complement interview with observation?
Yes, that is the question.
I don't understand the question. I'm sorry. I mean, in terms of utilizing activity theory as a method.
Yes.
Yes. Well, that's commonly done. I mean, in my own work, for example, with operating theatre teams or on the wards, where we videotape and then use live videotape replay for a review of what people have done through the day in their work. We would do interviews, we would use questionnaires, we would do open talk. So I think within, yes, Tim, please.
Yep, okay.
Thank you very much for the question. So you're thinking of this, if you like, as qualitative research and sources of data, and you're concerned that if we just use interviews as a source of data, we may miss what's going on in reality out there. Is that the question? And if I may respond to that, a lot of it is not about gathering data and going away and agonizing about them. It's about actually being there, talking to people, interacting, and so it is an action involvement process. So, yeah, I think, would that be my answer?
Well, yeah, so in fact, you know, the versatile data is the very essence of activity theory, and not only used by the researchers, but, you know, in activity theory you use the data for developing the processes with the participants, so it's very versatile. Well, there are a couple of questions there. There's at least one over there.
Good morning, Alison Ledger from Leeds. Thank you very much, Alan. You brought together two of my main interests in medical education, activity theory and medical humanities, so thank you very much. Mine is a clarifying question. For me, something that's been missing from the conversation this morning has been the value of change lab methods in achieving the change, getting community buy-in, and coming up with possibilities that perhaps wouldn't have been considered otherwise. So I want to hear a little bit more about who was involved in making this change possible at Peninsula. Who were the different voices? Who were the different perspectives?
Yeah, it's a really good question. I can just cut to the chase by saying that one of the things that we did was that we involved the public in making decisions. And I talk about the public. I mean, when we talk about patients, it's just rubbish, isn't it? Because we're all patients. And all the doctors in the room and the healthcare workers in the room, patients too. So we are the public. Well, one of the things that we decided to do was that one of the roles of the medical humanities is surely to get artists who work with public engagement to do projects and take them out to the public so they can have a conversation about. So we employed, for example, I talked yesterday about Christine Borland, an artist from Glasgow who we employed. We got a professor of music and medicine. We had writers and so on, and they took their work out. For example, Christine did a public show in which she looked at the whole business of teaching of clinical skills. So she took Sim Man and asked, where is the Sim woman? And then made a Sim woman from modeling her own body. And then she looked at the Sim child and put the Sim family together and made several incredibly good films about the Sim family. But the important thing was, in relation to your question, which she took that out to galleries where the public could walk through and engage with that. So yes, those voices are very important. And they did feed into our curriculum planning. Yep.
And couple of, yeah, well, I think I have to, you know, just cut down because we're about to wrap up, but would you please ask a question?
Rebecca Zabo from Melbourne, Australia. I have a question, Alan, thank you very much for an interesting talk, about the feminisation arm specifically. I'm really curious as to the choice of term for that rather than humanise, particularly given you've talked about medical humanities as the third arm. I think there's a risk that it is not inclusive of all genders, particularly in the frame of full diversity and inclusion. So can you elaborate on why it's specifically feminisation and not humanisation?
What, so could you clarify your question? We didn't really hear it or understand it.
So if it's medical humanities, which is representative of all genders, the risk of making it feminised shifts it to another frame which does not include all genders and does not include the people that are not embracing of feminism as well. So given it's medical humanities, why have you chosen that specifically?
Yeah, I think what you're doing is making a comment which is perfectly valid, and you made the comment.
I'm actually genuinely curious, is because you're coming from medical humanities.
I still didn't get the question.
Well, I think you could talk with Alan after this or sometime during the conference, because We're just about to wrap up, and before that, I'd like to ask Yrjö's comments on Alan's work.
Yeah, very quick. Just one comment. When Alan described the quality of this community that you have been developing, and you used those three terms, the democratizing, feminizing, and tender-mindedness, and you then put them in the community. And I'm wondering, you mentioned that your students have been well prepared to move to actual medical practice, but there is a different community waiting there, I suppose. And so I'm kind of wondering how to follow up and perhaps push forward that these types of community development happen also outside the medical school. Here's perhaps a connection also to the work of some very good organization scientists, particularly Paul Adler and Heckscher. They wrote a book called a book about collaborative community, and I wonder if these notions of collaborative community could be somehow connected to what you're looking at, because in the end it's not easy for an individual student moving out of a, let's say, very benign community environment in the medical school and facing the reality at work, where the community might be quite different. That transition and that kind of bridging, I think, would be quite interesting to see how they deal with this, and what kinds of seeds of a collaborative community might be found in healthcare organizations where your students are entering.
Thank you, Yrjö, and thank you all in the panel. I think I forgot to tell who I am at the beginning, so let's do it at the end. I'm Eeva Pyörälä, Senior Lecturer of University of Pedagogy from Helsinki. Just to make some concluding remarks very briefly, I think we are going to see the world in triangles for a couple of days, aren't we? I hope this symposium has inspired and encouraged you to study complex contexts. And you know, sometimes you think that this is so difficult, I don't want to even touch it. But you know, I think in activity theory, we all think that, well, wow, that's very interesting. Let's go for it. But as Yrjö said, you know, do it with your friends, create communities, create groups, and like this group, as Alan told, when we started discussing, it has been a very important discussion. Throughout the summer, we started already 1 year ago, but just go for it. You know, I think medical education lacks research on change, on difficult situations, problems in communication and collaboration, involving patients, involving beauty in the human life. So I think I'm really proud of being here with you, and I think this has been a lovely trip. And even though I don't know how to sail, but I think I've been kind of trying to sail this group up until here, and I'm so satisfied of hearing you and discussing with you all. So thank you everybody for coming here, and I hope you bring something at home with you. You will have more information of us there, you know, because I think often, you know, you don't know who these people are, but you also have a nice list of literature which might help you to begin